Real facts in epidemiology. So this is my second time making the intro. Why? Because the first time around I went and read up to here and I realized that all of this stuff is already covered in step 1, read with me, and I don't want to waste your time. So if you forgot anything from the step 1 about biostat, I recommend you just go ahead and read the first portion, the step 1 portion of the read with me. I'll add one of the things that I did in there, which was I did the questions. I'll add those in this video. But other than that, everything else it's better explained in that video. So go ahead and watch that bit. Something that I feel like it's not covered in the first portion as much, I'll cover it here. So you can see all of this is from step 1. Comparison of study design. So whatever is like missed out on, I think we'll just pick it back up from UWorld, but other than that, everything is pretty much covered in step 1 biostat portion. All the clinical trials, all that stuff, effect modification, and this statistical testing. Okay. What is this? Yep. So all of that, we'll do that. Pretty much everything is covered. So the vaccination portion, I'll go over that because it's much in depth here. But other than that, I don't feel like I need to read much other than this for step 2 here. So I'll read the last few pages of the chapter. Alright. Before that, I'll cover the questions in this chapter. Okay. So this is the video I'm referring to. USMLE Read With Me, First Aid, Biostatistics, PHS, Dr. Nandan Joshi. It has 4K views already. So it is helpful. This is what I use for my step 1 revision as well. Okay, so public health, it starts from there. I'm gonna go ahead and watch this after I'm done with this video making. It's 5 hours, so on times 2 it shouldn't take that much time. Okay. A hypothetical study finds a positive association between poor sleep habits and the risk for Parkinson's disease. The RR is relative risk ratio is 10 and the p-value is 0.4. How do you interpret these results? Okay. There is no sufficient evidence to reject the null hypothesis, and therefore there is insufficient evidence to support an association between poor sleep habits and the risk for Parkinson's disease. Remember that the null hypothesis always assumes that there is no association between the exposure and outcome variable if the p-value is more than 0.05. Then you cannot reject the null hypothesis. Okay. Let's try this out. Assume the data below are a hypothetical case control study. Calculate and interpret the OR. Okay, so OR odds ratio equals AD over C and B, right? We have disease status and exposed. Okay, so if we were to draw the box, we will have exposed on this side, plus minus, and this is the diseased. Okay. So who has the disease? It's 283 here, and then doesn't have the disease, and this, okay, wait, 283 would be, okay, so this is positive, cases, positive. Okay, so this person, these people don't have it. Oh wait, the controls will be the negatives. Okay, got it. This is taking some time, just bear with me. No one knows, so 210 will be here. Exposed, yes. So that's 182 there, and 263 here. Is that right? 263, they don't have the disease. They're not exposed, but they're in the disease column. Yes, okay. Cases, 283, they're exposed and they're in the disease column. Okay. 182 are exposed, yes, but they are not in the, they are exposed, but they don't have the disease because they're controlled. Okay. And 210, they don't have the disease and they're not exposed either. Okay. And so if this is A, B, C, and D, so what we are doing is 283 times 210 divided by 263 times 182, right, which equals 283 times 210, okay, 59,430 divided by 263 times 182, 47,866. Did I do something wrong here? Let's see. 59,430 divided by 47,866. So 1.2 is the answer. No, wait. Yeah, 1.24. Let's see how much messy that was. 1.24. Oh, we got it right. Yay. Okay, so I placed them correctly. Okay. So just remember the exposed and disease one, and then just play. You're gonna have to rearrange the chart for this to work, and then you'll get the answer. Honestly, this has been such a while since I did some kind of calculation, so I'm quite happy with this. Interpretation: the exposed group had 1.24 times the odds of having disease compared to the unexposed group. Okay. Okay, cool. Vaccines work by mimicking infections and triggering an immune response in which memory cells are formed to recognize and fight any future infection. They work as mode of primary prevention. There are several different vaccine formulations as indicated in this table. Recommended vaccination schedules for children and adults are outlined in this and this. Okay. Types of vaccination: live attenuated. These are your measles, mumps, rubella, polio, yellow fever, influenza, nasal spray, and varicella. Inactivated or killed ones are cholera, Hep A, polio, Salk, rabies, and influenza injection. Toxoid, diphtheria, tetanus, subunit, hepatitis B, pertussis, streptococcus pneumonia, HPV, meningococcus, conjugate HIB. HIB is H influenza type B, S pneumonia, and RNA based are COVID-19 vaccines. So this is cut off. But Hep B, it says here. Okay, nope. This doesn't help. Okay, can't see much. Let me just open up this page on my book. Okay, so oops. First one is Hep B. You take the first dose at birth. Second dose within 2 months after that, and then from 6 months to 18 months you take the third dose for Hep B. Okay. This is rotavirus RV1 second dose series. RV5 is 3-dose series. Oh, okay. 2-dose series is rotavirus 1, and rotavirus 5 is 3-dose series. So you take the first dose at 2 months, and then between 4 months and 6 months you take the second dose. Okay. Diphtheria, tetanus, and acellular pertussis. DTaP, less than 7 years. Okay. So all of them you take it before you reach 7 years. Okay. First dose is at 2 months as well. Second dose and third dose within 4 and 6. Fourth dose is 15, and fifth dose is there. Okay. So far at birth we are only doing HBV, Hep B, right? Influenza, same thing right here. First, second is between 2nd and 6th, and then 12 and 15 months is third dose for Haemophilus influenza type B. Pneumococcal conjugate PCV13, this is an important one. First dose at 2 months, second dose at 4 months, third dose at 6 months, fourth dose at between 12 and 15 months. Okay. Then we have poliovirus, inactivated poliovirus, IPV, less than 18 years, is 2 months is first dose, and second dose is 4 months, and then between 6 months to 18 months, third dose, and then 4 to 5 years to 6 years is fourth dose. Okay, so these were your in the beginning of life doses. Okay, and then here we have this is a influenza. Influenza dosage. Okay, so annual vaccination 1 or 2 doses. Annual vaccination 1 dose only after 8 years. Okay, so if 1 or 2 doses before 8 years, and after 8 years 1. Or you can have influenza LAIV 4, it says. Okay. Annual vaccination at 19 or 23 months. Okay, so after 2 years. Annual 1 or 2 doses, and or after 8 years, annual vaccination 1 dose only. Okay, then we have measles, mumps, and rubella, MMR. MMR we do at 12 months, so after 1 year. And here we have between 4 to 6 years, you have the second dose. Same thing for varicella, that's varicella over here. 1 month, first dose at after 1 year, and second dose after 4 to 5. Okay. Hep A, 2-dose series, between 1 and 2 years. 2-year-old. Okay. Then we have meningococcal. It's one dose at first dose is at after 10 years, and and the second dose is at between after 15 years, before, so during 16-year-old. Okay, at 16 you're taking second dose, at 11 to 12 you're taking first dose. Okay, that was meningococcal. Okay, then you have tetanus, diphtheria, and acellular pertussis, Tdap, more than 7 years. Okay. Meningococcal B, again, that's more than 7 years, I guess. This is 11, 12. I don't understand the boxes here. Okay, so that was first dose. Okay, so these are the first doses, just they didn't write it in. It's given here. Range recommended ages for certain high-risk groups. Range recommended for catch-up immunization. Recommended based on shared clinical decision making and can be used in this age group. Not routinely recommended. Okay. And then the last one was pneumococcal PPSV23. So it's recommended for high-risk groups. Okay, cool. So, continuing with the vaccinations. Here we have influenza inactivated or influenza recombinant. First dose annually after 19 years up to more than 65 years. Okay. Or you can take influenza live attenuated, one dose annually. Up to 50-year-old. Tetanus, diphtheria, and pertussis, one dose Tdap each pregnancy. One dose TD or Tdap for wound management. One dose Tdap plus TD or Tdap booster every 10 years. Measles, mumps, rubella, 1 or 2 doses if indicated. Born before 1957 are the indicated ones. Varicella is 2 doses born after 1980 and 2 doses of 46 to 65. Okay. Human papillomavirus, 2 or 3 doses depending on age or initial vaccination or condition. Zoster recombinant, 2 doses of immunocompromising condition, 2 doses here. Pneumococcal is here, and this is here. Just this. Yeah, this is quite boring. I'm just gonna skip it at this point because I'm not gonna retain any of this unless I'm doing questions and knowing what to look out for and what type of questions they ask. So stay tuned for the biostat and epidemiology notes, because this is a horrible way to remember this. Hopefully I'll have a better idea of how to organize this by the time we get there at the notes, and after I get through the UWorld. But I'm gonna zoom into this if you want to pause and just read it. Same thing here. I'll zoom into this so you can pause and read it, because I ain't wanting to do that. Okay, so live vaccines should not be administered to patients with immunosuppression. They are also contraindicated in pregnant patients, owing to a theoretical risk for maternal fetal transmission. A possible exception to this rule can be some asymptomatic HIV/AIDS patients who may be a candidate for the measles, mumps, and rubella vaccine. COVID-19 vaccine. At the time of writing this book, in the light of the ongoing pandemic, COVID-19 vaccine are recommended for everyone aged 6 months and older. Number of doses, duration between doses, and need for booster doses vary from manufacturer. 3 commonly available vaccines are Pfizer, BioNTech, uh, Moderna, and Johnson and Johnson. We don't count that one. Screening recommendation. Okay, so this outline recommended healthcare screening available by gender and age. Okay, so health screening recommendation for women by age, and this is for men by age. Okay, so age in years 19 to 31. Recommended cardiovascular recommendation: cardiovascular vaccine, breast reproductive vaccine. Wait, not vaccine. Sorry, screening and other screening. Okay, so between 19 to 31, so you probably, blood pressure screening at least once every 2 years, cholesterol screening starting at 20 years of age for patients at increased risk of heart disease. Okay, so increased risk of heart disease. Screening starts, okay, cholesterol screening starts at 20 years of age for patients at increased risk for heart disease. Got it. Breast reproductive, pap test every 3 years starting at age 21. Co-testing pap plus HPV may be done every 5 years starting at 30 years of age. Chlamydia tests yearly until 24 years of age if sexually active. Women of more than 25 years of age should be tested only if there is an increase in risk. Okay, so chlamydia up till 24 years, and if it's more than 25, then only if there is increased risk. Pap test every 3 years starting at 21, may be done every 5 years starting after 30 years. HIV test at least once to ascertain status. Test for gonorrhea and syphilis if at increased risk. And then others: diabetes, blood glucose or HbA1c screening starting if blood pressure is more than 135 by 80, or taking medications for hypertension. From 40 to 49, blood pressure screening at least once every 2 years. Okay, so we'll continue to doing that. Cholesterol screening for women more than 45 years of age. Okay, what was here? Starting at 20 years of age for patients at increased risk for heart disease only. Okay, so this is regardless of the risk status. Pap test every 3 years, or co-testing. Okay, same thing as that. Every 5 years. Okay, so co-testing is done every 5 years, similar to this. Okay, pelvic exam yearly, chlamydia test if patient has new or multiple partners. Okay, this was after 24, up to 24, and after 24 only if it's high risk. Okay. HIV test at least once to ascertain status. Test for gonorrhea and syphilis if at increased risk. Diabetes, blood glucose or HbA1c screening if BP is more than 135 by this, or taking medication for hypertension. Colorectal for patients more than 45 years with no family history. FOBT is fecal occult blood test, okay, yearly. Flexible sigmoidoscopy every 5 years, or colonoscopy every 10 years. Okay. So colorectal we're doing for patients more than 45 years with no family history. FOBT yearly, and flexible sigmoidoscopy every 5 years, or colonoscopy every 10 years. Okay, so these are the recommendations. 50 to 64, blood pressure screening at least once every 2 years. Cholesterol screening for women more than 45 years of age. Okay, so this is the same for all of these now. Okay, same thing for 65 or above. BP screening at least once every 2 years. Cholesterol screening for women more than 45 years of age. Okay, mammogram once every 1 to 2 years, can start at 40 years of age if patient chooses. Pap test every 3 years. Chlamydia test if patient has new or multiple partners. HIV test at least once to ascertain status. Test for gonorrhea and syphilis if at increased risk. Diabetes, blood glucose, or HbA1c screening if BP is more than 135 by 80 mmHg, or taking medication for hypertension. Bone DEXA scan can be done in patients with other osteoporosis risk factors, colorectal, FOBT yearly, flexible sigmoidoscopy every 5 years, or colonoscopy every 10 years. Okay, that's similar to this, right? Okay, but the thing that we started doing is DEXA scan now after 50. And more than 65, blood pressure screening at least. And DEXA scan here can be done in patients with other. Oh, okay, it's because of the risk factors. Okay. Because I remember from View World they said we do it for everyone over 65 years of age. Okay, so DEXA scan at least once after 65, or yeah. Okay, 65 mammogram once every 1 to 2 years until 75 years of age. Discuss PEP test with physician or nurse. Chlamydia test if patient has new or multiple partners. Discuss HIV test with physician or nurse. Test for gonorrhea and syphilis if at increased risk. Okay. Diabetes, blood glucose, or HbA1c screening if blood pressure higher than 135, or taking medication for hypertension. Bone is this, DEXA scan for at least once, and colorectal screening with FOBT, sigmoidoscopy, or colonoscopy every 10 years until 75 years of age. Okay. For men, 19 to 31, cardiovascular, blood pressure screening at least once every 2 years, cholesterol screening at least starting at 20 years. This was 21? No, 20 years as well. Okay. Screen all men more than 35 years of age. Reproductive, both partners should be tested for STIs, including HIV, before initiating sexual intercourse. Test for syphilis if at increased risk, nothing else. Okay, for up to 39. So just blood pressure and cholesterol and HIV and STIs. Okay, syphilis. 40 to 49. Sorry. Blood pressure screening again, at least once every 2 years, and cholesterol screening for all men more than 35 years of age. Reproductive, discuss DRE and PSA with physician and nurse. HIV test at least once to ascertain status. Test for syphilis if at increased risk. Diabetes, blood glucose or HbA1c screening if blood pressure is more than 135. Taking medication or hypertension, and this is the same as the previous gender. 50 to 60 years, 4 years, same thing. Lung. Okay, so cancer screening with low dose CT for individual with more than 20 years. Smoking history who are presently smoking or quit within the last 15 years. And more than 65, same thing. Abdominal aortic aneurysm, one-time screening for men who have ever smoked or have a family history. Lungs cancer screening with low-dose CT for individual age less than 81 with more than 20 years smoking history who are presently smoking or quit within the last 15 years. Okay. Reportable diseases. By law, disease reporting is mandated at the state level. Add the list of diseases that must be reported to public health authorities varies slightly by state. The Center for Disease Control and Prevention has a list of nationally notifiable disease that states voluntarily report. Okay. These diseases include but not limited to those listed in this table. Common reportable disease are STI, for example, HIV, AIDS, syphilis, gonorrhea, chlamydia, chancroid, HCV. Tick-borne disease are Lyme disease, ehrlichiosis, Rocky Mountain spotted disease, fever, potential bioweapons, anthrax, smallpox, plague, vaccine preventable disease like diphtheria, tetanus, pertussis, measles, mumps, rubella, polio, varicella, HIV, HPV, H influenza, invasive meningococcal disease. Water, foodborne disease, cholera, giardiasis, Legionella, listeriosis, botulism, shigellosis, sugar toxin, producing E. coli, salmonellosis, trichulosis, typhoid, zoonosis, tularemia, uh, pisticosis, brucellosis, and rabies. Miscellaneous are TB, leprosy, toxic shock syndrome, SARS, COVID-19, West Nile virus, VRSA, vancomycin resistant SA, coccidiomycosis, cryptosporidosis, and MRSA is reportable in um, several states. Okay, I think I wanted to go over. There was a COVID-19 section somewhere. Did we already cover that? Oh yeah, we covered that. Okay, yep, that's it. For this, all the rest of this is going to be covered in step 1, FA read. So I'll see you here. Until next time.